Welcome back to Teddy Talks, a podcast created by UCL Paediatrics Society by medical students for medical students, where medicine meets mischief and we discuss all things pediatrics from teddies to training pathways.
Yep, we're bringing you along with us as we dip our toes in the vast array of subspecialties in pediatrics. And if you're a medical student interested in pediatrics but don't know where to start, just like us, then you're in the right place.
I'm Yamina, I'm one of your co-hosts, and I'm currently in my second year of medical school.
And I'm Letitia, your other co-host, and I'm a fifth-year medical student. So, last episode, we had a little look into adolescent mental health and even spoke a bit about the relevance of the Netflix series Adolescence in there somewhere. So if anyone's interested, there's a little shameless self-plug there. But today we wanted to take you back down the age groups for a second and speak about neonatal care.
And we're so lucky to have Dr. Naomi Jones join us today to share her own experiences in the field. Naomi is an incredible speaker, and some of you may have heard her talk on medical ethics in cases of extreme prematurity if you were there at Gosh Summer School this year, and we're thrilled to have her on. Naomi is a neonatal registrar at the ST7 level at St George's Neonatal Unit. She's completing her training in general paediatrics with a neonatology special interest, or SPIN, but her accolades do not stop there, as she has clear interests in medical ethics and education, evidenced through her completion of a master's with distinction in health law and ethics from the University of Manchester. She has co-written the chapter on confidentiality in the recently published textbook Diverse Voices in Health Law and Ethics, Important Perspectives, and has completed a clinical teaching fellowship at UCLH/UCL alongside a PG cert in medical education, and currently serves as an honorary clinical lecturer at UCL. Her passion lies in pediatrics and neonatology, with a strong commitment to inspiring and training the next generation of pediatricians. So, Naomi, it is amazing to have you on, and welcome to Teddy Talks.
Wow, thank you so much for that introduction. And thank you for inviting me on as well. It's great to be here.
Honestly, thank you so much for joining us today. We're really excited to talk a little bit about all of this stuff because we think that you have lots of good insight about neonatal care. I think it would be great if we just start off with discussing a bit about what being a specialist on neonates really involves, if that's okay.
Of course.
If I'm not mistaken, as neonates include babies in the age range of around 0 to 28 days old. Is that correct?
Technically, yes.
Yes.
But practically it works a bit differently to that.
Oh, really?
In that so on NICU, basically, we have babies who, we take them as soon as they're born, pretty much. And some of them are with us for a long time. So some of them just, we have babies who are with us for 100 days. Sometimes, get to several months old before they get home. So, they don't automatically go home when they hit 28 days.
Oh, right. Okay.
Or be transferred either.
Yes.
Wouldn't work out like that. But yes, so we do have some who are older than that as well.
Okay, thank you for the clarification then. So we're also aware that these are the initial moments of life for these babies. Their bodies are being introduced to a completely new world as compared to being suspended in amniotic fluid for months and months. And they're losing things like their connection to their mother through their umbilical cord and things like that. So a lot of key critical processes occurring in these first few days. I was wondering if you could talk to us a little bit about what things could go wrong and what kind of patients you normally see.
Yeah, absolutely. So one great thing about neonatology as a specialism is that it's so varied. So you're right, there's lots of different physiological transitions between life in utero compared to life ex utero. And we deal with babies all the way from those who are well on the postnatal with their mums, who maybe need a little bit of extra support, maybe some antibiotics or feeding support or something like that, all the way through to the ones who are the most poorly, who have to come on to neonatal ITU. And we also have different levels of care in between that. We've got special care and we've got high dependency as well. So it's so varied. As neonatologists, we go to deliveries, and I have to say I do less of that now that I'm a registrar, but as SHOs you go to quite a lot, not every delivery that happens, but quite a lot, to give babies any additional support that they might need with transition into life in the world. So we look after all sorts of babies with all sorts of of things that they might need help with. So thinking about, as I said, the ones on postnatal ward might need some antibiotics or feeding support. The ones on ITU might need some help with their breathing. So all sorts of different problems can happen with breathing. Might also need help with their feeding, their brain, that sort of thing. We have cohorts of children who are preterm, who come to the neonatal unit for different levels of support depending on what gestation they are and how poorly they are. So that's most of those babies are born preterm in an unplanned way. Preterm labour has happened for whatever reason that wasn't planned, but there are a few that perhaps for maternal or fetal reasons have to be delivered preterm and then come to us. So we have a group of those babies. We then have a group of term babies who either might have a congenital abnormality that we already know about, that we're expecting them, and they come to us after they're born, and parents are warned about that for various different reasons. And then there are some term babies who also might come out and unexpectedly need to come to us for help with their breathing. Sometimes if there's been concerns about hypoxia in labour, they might need to come to us for neurological care. So there's a whole host of different reasons. St George's is also a surgical centre. So we partner with our amazing paediatric surgeons and paediatric neurosurgeons. So we have a cohort of some babies who might have been born in another hospital and then who either are postnatally diagnosed with a congenital abnormality or who develop a surgical or neurosurgical problem, who then come to us for ongoing assessment and care under the surgeons as well.
Okay, perfect. So now that we have a bit of a kind of insight into the type of patients we're seeing within neonatology, this is a bit more of a personal question, I think. And I'm really intrigued by why you chose neonates specifically. So what do you think what did you find most special about this stage of child development? And why did that draw your attention compared to infants, toddlers, school-age children, or adolescents?
Yeah, it's interesting because when I started my peds training, right, you have to do a bit of neonates. And when I started it, I chose my rotations to do the minimum amount of neonates that I had to do to get through. I was like, no, I'm not interested. I want the toddlers. They're much more fun. Yeah, I'll just do whatever neonates I have to do to fulfill my curriculum, whatever. But then the more I did it, the more I loved it. And I think that just sometimes happens in life, right? You kind of find yourself doing something unexpectedly that you really love. And I love neonates for so many reasons. I think babies are incredible. Like, they go through so much. As I said, we've got so many different cohorts of children that have to go through so much. And most of them come out the other side, and we look at them in such a holistic way, which I really love. The other thing about neonates for me is that there's such that variety. So I love the intensive care stuff. But I also love the follow-up, the high dependency, the special care, and we see these children in clinic as well. So I have done a job in paediatric ICU where you just do the intensive care and then they get stepped down and you don't really follow them up very much. And that's just part of that experience of that specialty, which works for some people, doesn't really work for me. I missed that follow-up. For me, it's important to have the longitudinal relationships with the families, and to really see like what happens to the babies and as they grow up into children, and sort of how we can make a difference to their lives. Those first few days, weeks, months are absolutely critical, and there's so much that we can do to make it as good as we can. Yeah, I think putting it all together, like I get to do so much of a variety, which I really, really like, and that means a lot to me moving forward. So yeah.
Okay. I actually have a question about that kind of patient interaction that you were kind of describing. So, I mean, I've just finished my first clinical year, and I'm still yet to start my pediatrics rotation next year. But all the patients that I've met so far have been able to communicate quite well to me about what their pains are, their story, their entire kind of patient journey is. And building this connection with the patients is one of the things that I love most about these kind of clinical placements. In neonatal medicine, I'm sure you find that you kind of end up talking or communicating more with the parents of the neonates that you care for rather than the neonates themselves. And we were just wondering how you find the interactions that you have with patients and their families. How do you find that as a neonate
Yeah.
registrar? And how does that differ from like your usual interactions with like an adult patient, for example?
Yeah.
Yeah.
So I've not looked after an adult since I've been doing paediatrics. So we're talking about 8-9 years now. So mostly children. I mean, as you say, like adults can most adults can tell you their history and can describe their pain to you. I would say most children probably can't do that. And not even just neonates. If you ask a toddler whether their pain is burning, stinging, cramping, they have absolutely no idea what that means, right? So yeah, there's, to a certain extent, there's an overlap. Obviously, if you ask a teenager that, with most teenagers, you'd expect to have more of an idea. Children change with their maturity as they grow. So yeah, there's an element that like in pediatrics in general, not just neonatology, we have to be really skilled at communicating with parents and getting the history from the parents and getting parents to describe what they're seeing with their child or their baby or their young person. But simultaneously, you also have to be able to communicate with a toddler or an older child, or be able to say, okay, where's the pain? So it's different in pediatrics in general. It's funny that you ask about neonatal specifically, because when I said I wanted to do more neonates, it's something my mum even said to me. She was like, but you love playing with kids, you love talking about Bluey and like having some jokes about whether there are dinosaurs in their tummy, because that's what you do when you're an A&E with a 2-year-old.
Yeah.
Like, why do you want to do neonates? She's right. It was like, obviously the babies don't verbalize to you, but there's so many different things that you can get. So babies do communicate, just in a really different way, and I think that's kind of underestimated. And certainly before I started doing peds, I was like, oh, they don't communicate at all, but they really do. And it's so important that like whenever we're examining them, whenever we're going to go and do a blood test or whatever, that we go and see them. I talk to the babies all the time, even the sickest, most preterm babies. Just before I examine them, I'll just say hi, basically. And it is helpful for them, like from a neurodevelopmental point of view, that you're not just suddenly waking them up from being asleep to going and doing something painful, because that would be grim for any of us, right? But that helps their pain, and then that helps their neurodevelopment. So I get some reward from that. But I think you're right. You build the relationship up with the parents. And you guide parents through what is a hugely stressful time. Nobody expects to have their child need neonatal care. Like, nobody does. When you imagine having a family, nobody thinks, okay, well, that's going to involve several months on a neonatal unit. That's going to involve me having to go home and leave my child in hospital. No one expects that. And so that can be deeply stressful for parents. And so it's part of our job to help mitigate that as much as possible, to build that rapport with parents and to kind of support them through it. And you do have to get history from parents sometimes, particularly, some of our babies who are transferred in, or when we're asking for a bit more information about what happened at birth, parents have some of that information. But also often our parents who are on the unit for a long time, they know their babies the best. Like, we've obviously got our notes, which are really detailed, but sometimes because it can be hard to see the wood from the trees, and parents really know what is the key thing for their baby, like what are the most important issues, what are their priorities moving forwards. And so there's a big movement in neonatology to do what's called family integrated care, to really make sure that families are integrated as part of the team, that parents are partners in care. They love their babies, and that is so valuable, and that's something that no one else can do, and that's absolutely key. And so we really encourage parents to be parents as much as they can within the confines of having a poorly baby. So doing things like the cares, the nappy changes inside the incubator, we teach them how to do that. We teach them how to hold baby within the incubator. We help get them out of the skin to skin and stuff when baby's well enough, and that's all those sorts of things, really, really important. And I get a lot of satisfaction from that, and from building up those kind of relationships and supporting parents through that. I do have I don't, thinking about like older children and stuff. I don't have children of my own, but I've got loads of friends who've got kids. So I've spent a reasonable amount of time with children in my life, and volunteer with my Sunday school at my church for older kids and stuff. So I have that element in my life just outside of work. And yeah, I find the way we communicate with parents at work to be so important. And I don't find myself missing the blowing bubbles. Like, I love it when I do it, but I've been doing this current job now for 6 months, and I don't think, oh gosh, I wish I could be doing that. I know I have colleagues that do, that I have colleagues that are like, oh yeah, I want to go and like talk about tractors and with a child and stuff. But that's fine. We're all different, right? And for me, like, yeah, I get enough of the communication with the parents. It's so important, building up those relationships and seeing those babies through, sometimes from day one all the way through to when they're discharged. And I get so much reward from that. I find that to be like hugely, hugely valuable.
Oh, it's a really lovely reflection from that. I think from our discussion so far, I think it's pretty clear now how different the management of neonates are from adults in a sense. And we've just spoken about the kind of lack of means of communication, which I think we've spoken about the kind of interaction between parent and patient and patient and doctor now. I think also it really gives rise to a variety of ethical issues. And we've been quite curious about this kind of intersection between neonatal medicine and medical ethics. And we thought this would be a perfect topic to talk about with you, Naomi.
Yeah, of course.
Yeah, so Yamina and I are both quite interested about the extreme cases in neonatal medicine. And I heard from Yamina that you did a talk about this as well in the Gosh summer school. Yeah, so I heard in a podcast, not sure if this is correct or not, please correct me if I am wrong again, that 22 weeks is kind of somewhat of a cutoff about when we start thinking about having a aggressive perinatal care and thinking about viability of the neonate. But after doing a bit of research, I also found that the survival is actually around under 15%, and it's very common for these babies to develop profound disabilities. So I guess my question is, at what point is viable enough to warrant aggressive perinatal treatment? Or at what point is, how do you even make this decision, balancing the wishes of the pregnant woman or the family and also the best interest of the neonates themselves?
It's tricky. It's a really interesting thing to think about. So, with regards to viability, so viability is still 24 weeks, and it's a legal definition that hasn't changed. So that's still 24 weeks. But you're right, there's kind of a grey area for 22 and 23 weekers, and the national guidance changed in autumn of 2019. To say that we might, so not that we would always, that we might consider offering survival-focused care for these babies. And that doesn't necessarily mean absolutely everything. It doesn't mean doing everything completely aggressively, but it involves an individual risk assessment. So, for example, if you had a baby who was due to be born at 22 plus 0 weeks, that had lots of unfavourable risk factors, so things like antenatal steroids, sepsis, the size of the baby, is the baby a singleton or are they multiples? All of those things come into play, and you do your sort of individualised risk assessment. And if you've got a situation where there's lots of unfavourable risk factors, then actually you're probably going to say to this family, I'm ever so sorry, but baby is just too early to be able to survive, and we recommend that if baby is born today, that we move to palliative care, to comfort care, that we allow them to pass away peacefully in your arms, and that they have a really precious time in their life, even though it's going to be really short. And lots of those babies who have all those risk factors very sadly don't survive labour either. And so there's an element of that as well. It's hard. It's really hard when those things happen. However, there are some babies who are born at 22, 23 weeks, actually, for whom survival-focused care might be appropriate. So say, maybe, again, it's all individual risk assessment. So let's say you're more towards the end of the 22nd week or in the 23rd week. Let's say there's been perinatal optimization like antenatal steroids. You're in the right place, because that's also important that we know that the survival rates if you're born at a unit with a level 3 NICU are better. Again, thinking about sepsis, estimated fetal weight, all those things. Again, we put all those together, and there are times we might say, okay, yes, you're 22 weeks, but the other risk factors put the baby in a more favourable risk category, and therefore for this baby we might offer survival focused care at birth should they survive labour. And that usually means airway management and breathing management. So that usually means face mask ventilation initially, and then we'd usually intubate them and then continue supporting their breathing and monitor for response. So that's usually as far as we would go, because we know that there's not as much evidence for sort of additional resuscitation efforts for babies born at those gestations in terms of them being successful. So that's essentially what the guidelines are in a nutshell. But they're being reviewed at the moment to kind of, it's like anything, isn't it? Once they've been in place for about 5 years now, yeah, they're undergoing a review of some of the finer details. But that's essentially what the guidance are, and will probably be a similar kind of thing after review as well. So that's essentially what it is at the moment for those extreme preterm infants. And as I said, when I was at the Gosh Summer School, like, it's really interesting and can be really complex trying to kind of pick out these details and have these conversations. And sometimes, unfortunately, and very sadly, actually, the best thing to do for that baby is to offer palliative care. And that's, might be very difficult for families, but often we know actually it's the best thing for us to offer for them.
Yeah. I think that really nicely links to a concept that you mentioned at Gosh Summer School, which is the idea that we shift our focus from trying everything to trying everything that helps. And that must be such a difficult conversation to have, but I think there's a lot of panic associated with these kind of situations, especially in extreme prematurity. And this links kind of onto our next question, which is, online. I think the online space is amazing in the sense that we have access to so much knowledge that we didn't previously. And we still often hear about these kind of miracle babies or neonatal patients who really exceeded their expected life expectancy. And these stories are so popular because of, how miraculous they do seem. And I think these kind of stories will obviously give a lot of hope to parents, but may also similarly kind of set unrealistic expectations over the care of what doctors can actually give and provide to their children. So how do you think that the media has affected parents, and how do you kind of balance that kind of expectation and having realistic goals and hopes?
Yeah, it's interesting because I have to say, again, I've seen all of those stories in the media, and you're right, what makes a good story is the miracle ones, or the ones who do survive. And
Yeah.
there are some 22-weekers who have survived, and of course that makes a good story. In my experience, and I'd have to have a chat with my consultants about it, in my experience, I've not really had parents come to me with stories in the media and say, but look about this baby. So I've not really had that personally. I've had parents on the unit, because when parents on the unit for a long time, they obviously get support from each other, and so they do talk about their babies, because of course they do. It's very natural. So occasionally you might get, but that baby in the other room had that treatment and that helped them, so would it help my baby? And I have to say, most parents are really receptive to us saying, very valid question, but this is what is different for your baby. Obviously without breaking anyone's confidentiality, of course, but I think, and I think the same with the media. So there are stories of the babies who survived in the media. It's particularly, thinking about those risk factors. So we often don't know some of the details of the risk factors of the babies in the media because it's not included.
Yeah.
But in general, I'll say to parents, it's a really valid question, completely understand why you're asking it. This is what's relevant in your situation, in your baby situation, that make us make this decision or make us make this recommendation in this situation. And in general, I find that people are really receptive to it. I think in general, in most of my experience, most people don't actually really know much about neonatology. Most parents don't know anything about having a preterm baby because there is a huge amount out there. And so, of course, if they go into labour in an unexpected way prematurely, they're really, really scared, and that's completely normal. Because it's extremely difficult, and there is stuff out there about neonates from both ways, and sometimes you end up parents have done some research and things like that. Yeah, so I think it's interesting. There was a little one. I don't know if either of you guys happen to watch Gladiators, but there's a guy who stars in that who had his son Leo was born at 23 weeks. Gosh, I can't remember how long ago it was now. A few months ago, I guess, might be longer. But anyway, he very sadly died at 13 days old, and he and his wife had created a charity in Leo's name, and have kind of, maybe it's part of being a public figure, I don't know, that he has put on his Instagram about like photos of little Leo, and said, when he passed away and things, which I think is so brave and so beautiful. And they're doing stuff to try and raise awareness and raise money in his honor. So there's, there are both sides kind of out there, I guess. But yeah, it can be really difficult because, as I said, most people don't have any experience of neonatal care, and they think, oh, you must be able to do everything. And we have to sometimes say, well, actually, this is what we recommend for your baby. In general, like I said, in general, most people are receptive when we're kind of explaining things that in a targeted way for their situation. In general, people are receptive to that, I find. Yeah, I'd have to, maybe I'll ask my consultants when I'm next to work if they ever get it the other way. But that's been my experience.
I can imagine it's quite difficult for parents to even hear about having to have neonatal care in the first place. This must be quite a shock already. So yeah, maybe the shock from that and just like everything that's going on, the media is not maybe not as prominent in their mind when they're suddenly being told that their baby has to be in the NICU.
Yeah, I think you're right. It depends on the situation, doesn't it? If it's an unplanned delivery because you've gone into labour and it's all, you're not expecting it, versus if your baby's been diagnosed with a condition and they're going to have to come to the NICU and it's a planned thing, they've got a bit more time to kind of get their head around it. But also in those situations, they'll often meet us antenatally. We'll try and arrange for them to come to the unit to see what the unit sort of looks like as well. So, I think it depends on the situation as well.
True.
Absolutely.
So for our next question, we just wanted to talk a little bit more about medical ethics. We wanted to talk a little bit more about safeguarding. So we know that in general, in pediatrics, we appreciate that caring for children under the age of 16, there is an additional consideration of ethics surrounding, safeguarding that may not be as relevant in other subspecialties. And we were just wondering specifically about your own experiences with neonates. Have you ever encountered any concerns over safeguarding, and how did you recognize these, and like what kind of considerations did you have in kind of handling these situations?
Yeah, you're right. Safeguarding is key, and it's a big part of what we do as paediatricians. And it's just part of the job description. So yes, there are definitely safeguarding issues sometimes with neonatal care. It's different, obviously, to maybe older children who might, come into A&E with an unexplained injury, and then we have to kind of try and elicit processes and take things into consideration from that point. But yes, there are issues in the neonatal unit and in neonatal care. And the things we tend to come across might be if there have been concerns antenatally. So let's say there are other children who might be on child protection plans and already known to social care, then often there is, or certainly should be, a plan for the new baby being born and where they're going to go and how they're going to be supported. So that's a big one. The other big one that we see is probably substance misuse from the adults in the home. So we sometimes have to manage that medically for babies, but I have to say the medical management isn't that common. It's more the social management and how these babies are going to be supported, and these families are going to be supported in the community, and where is the best place for this baby to go when they're well enough for discharge. We also sometimes see incidences of domestic abuse, and so then again we have to work with our safeguarding colleagues and social workers to do whatever is the safest for our families and for this child. And I think overall they're probably probably the biggest groups that we have.
Have you ever encountered any concerns over safeguarding, and how did you recognize these, and like what kind of considerations did you have in kind of handling these situations?
Yeah, you're right. Safeguarding is key, and it's a big part of what we do as paediatricians. And it's just part of the job description. So yes, there are definitely safeguarding issues sometimes with neonatal care. It's different, obviously, to maybe older children who might, come into A&E with an unexplained injury, and then we have to kind of, try and elicit processes and take things into consideration from that point. But yes, there are issues in the neonatal unit and in neonatal care. And the things we tend to come across might be if there have been concerns antenatally. So let's say there are other children who might be on child protection plans and already known to social care. Then often there is, or certainly should be, a plan for the new baby being born and where they're going to go and how they're going to be supported. So that's a big one. The other big one that we see is probably substance misuse from the adults in the home. So we sometimes have to manage that medically for babies, but I have to say the medical management isn't that common. It's more the social management and how these babies are going to be supported, and these families are going to be supported in the community, and where is the best place for this baby to go when they're well enough for discharge. We also sometimes see incidences of domestic abuse, and so then again we have to work with our safeguarding colleagues and social workers to do whatever is the safest for our families and for this child. And I think overall they're probably the bigger. It's our job, obviously, to make sure that the baby is safe and to work with the professionals in the community to make sure that there's a safe and appropriate discharge plan for that baby.
Yeah, it's really interesting. I think especially this conversation we're having. At medical school, we're taught all about the different kind of reflection models and the idea of like biopsychosocial and having that kind of approach in regards to how we deliver any sort of healthcare, regardless of who the patient is. So it's really interesting how every single kind of decision we have to make we really do. You kind of see that in action. Which I'm only in my second year of medical school. I think it puts into like how it's kind of this training from the get-go really is going to stay with us for the rest of our kind of careers. So a bit of a switch now, with the increasing relevance and role of new technologies and how the roles they kind of play in our world today. We're seeing a lot of new medical innovations such as genetic testing and modification, AI-driven neonatal monitoring, stuff like that, all are kind of in the process of being introduced. However, these changes don't normally come without their own kind of set of concerns, whether those be ethical in regards to efficacy, etc. So what are the main debates being discussed surrounding these new technologies, specifically within neonatal care?
Yeah, interesting. I think you're right, and you've picked out a couple of really interesting things that are coming up moving forward. It's not something I kind of I've actually had much of a conversation with my colleagues on a day-to-day basis, but like reflecting on it, there are definitely a few things. So I guess if we think about the technologies element, in neonatology, we collect huge amounts of data from babies in terms of, they're on continuous monitoring all the time. So, we've got trends of heart rate, saturations, because they're on monitoring. So, there's an element, okay, what do we do with this? And there's an element that we are using new technologies. So it's quite widespread. There's an early onset neonatal sepsis calculator for well babies that basically uses Bayesian statistics you put in various different factors and it tells you whether or not how high the baby is at risk and should you screen them, should you just monitor them, something. And we use that quite routinely. And then there's another thing I've used in a different unit where the ventilator adjusts the oxygen based on what the saturations are to avoid either hyperoxia or hypoxia, both of which you want to try and avoid for babies. And that's been shown to be quite effective. It moves faster than a human being can, so that's quite good. And we also use a mode of ventilation at St George's, which is very technological. It's looking at neurologically assisted ventilation, which is really cool. So there are elements of technology that we use and we can use to benefit our babies. But like with anything, we still have to maintain our clinical judgment. So like with our sepsis calculator, if it says that the baby's at low risk, but I look at that baby and something just isn't right, then I'm going to screen them anyway. I'm not going to rely on that calculator. And so, with the oxygen thing, again, if that's not doing what I want it to do, then I'm just going to override it. I think we need to bear that in mind with any forms of medicine, any forms of technology, that if we're gathering the data or we're asking computers or machines to analyze data and come out with a risk for us, how much do we rely on it? And obviously we have to show that there's good evidence and stuff, but actually there are times where we have to also use our clinical judgment, and we need to be careful not to get complacent and say, well, the machine said that, so I'm going to follow that machine, even if there's something else that isn't right, because machines can't examine the baby for us. So yeah, it's sort of those sorts of things, I think, with any kind of technology. And particularly, I saw something in the news about potentially AI using to write discharge summaries in medicine in general, which, I mean, that would save us a lot of time. And we know that AI can summarize data in general reasonably well. But we need to be careful that firstly it's doing it correctly.
Yeah.
We don't just rely on it, but also that there's that compassion within it. Often, and I'm particularly keen on this, particularly with neonatal care, and especially if you're writing a discharge summary for a baby who hasn't survived, is writing it with sensitivity and writing it with compassion, because parents will take it home, whether their baby's gone home with them, whether they've been transferred, or whether they've sadly passed away, then they have that document. It's so important that it's written with compassion and written with sensitivity. Yes, the technology might be able to summarize the facts, but how do we put the compassion in? How do we put the decision making? How do we reflect that? And I think that's what's really, really important. So I guess they're kind of my immediate thoughts about like some of the technology that's out there. We also need to be really careful with any kind of data, and there's more and more thought about it now, that in terms of bias, and making sure that there isn't any bias reflected in the algorithms, particularly looking at data from children from different levels of neonatal units. So, there's no point using a risk calculator that's designed for children on the sickest units when you're actually on a different type of unit. So it's thinking about how that applies, and there's lots of uncertainty in data. There's, babies often have more than one thing going on with them, and so if we're looking at predictions, that we can't just say, yeah, but that's because of their lungs, when actually it might not be. It might be because of their heart or whatever. And how do we unpick that when we're writing these kind of programs? I'm sure there are people out there who've thought about that and hopefully designing that in, but they're kind of the things that I guess it's important that we think about. And obviously then you also mentioned this sort of genetic testing, and genetic testing in general we do relatively commonly, I suppose, not all the time, but especially because I'm at a unit where we do have children with congenital abnormalities, so we do test them for genetics for that, but that's usually in a targeted way, saying, okay, these are their clinical features. We might ask a geneticist as well to come and see them, and then they'll advise about the specific test. And that, I think, is fairly straightforward to do. Obviously, they're bringing in the newborn genomic screening stuff as well, which I find really interesting because, so they're essentially going to be looking at it and testing the data, testing for conditions that would present within the first 5 years. And with any screening test, there need to be tests thresholds that are met. So basically saying, if we intervene early, are there better outcomes? So for any screening test, whether you're talking about cervical smears or breast cancer or whatever it is. So all these things have to be met. And I think with the genomic testing, it's interesting because there might be some mutations, for example, where there's incomplete penetrance. So there might be incidental findings, because obviously the data that we have is for children who've presented clinically with these disorders, who also have this mutation. What we don't really know is how many people out there have a mutation with incomplete penetrance, who don't necessarily present clinically. And therefore, what does it mean for them? And I find that really interesting. The other thing I think is interesting is what happens to all this data? So it's a lot of data. It's an entire genome. That's a lot. And okay, fine, we're only testing it for the relevant things for that child. And I think that's really key, that we're not testing it for things like, increased Alzheimer's risk and stuff like that, because I think that child needs to be able to give that consent when they're 18. So I think that's key. But so fine, we've not tested it for those things, but we still have their whole genome on record, or we're still going to have their whole genome on record. I'm sure there's stuff in place to make sure that's secure and things like that. But it's interesting in terms of how are we getting consent from parents, taking that into account, and what might happen to that data in 5, 10, 15 years when that child is still a child. But people might say, oh, we've got this genomic data, like maybe we could test it. What I think that's really interesting, and I maybe need to do a bit more thinking and reading myself, because I'm hoping these things have also been thought about. But yeah, that to me kind of strikes me, I guess, in the kind of initial thoughts. It's got potential, if we can pick up some of the epilepsy syndromes that are difficult to treat before these children have difficult epilepsy, some of the metabolic diagnoses and things like that. If we can pick some of those up early, then I think there's potential for it to be hugely valuable. But I think we need to think about some of the other elements to it. And when we're saying things are high risk and talking about early treatment and stuff, hopefully, hoping this has happened, has that all been defined clearly, and what does that all mean and things like that. And maybe it all has been defined clearly and it's part of the design somewhere. But I guess they're the kind of things that I think about when thinking about it for me.
Thank you for sharing all of that. That's a really lovely summary of just how, yes, it's really amazing that the technologies are improving, and it's really good that it's quite hopeful what it can do for our babies. But also, we can't fully put all of our trust into it. And I think you've really highlighted really well how the human experience and the human touch is so important still in medicine, in any, and its relevance in neonates as well. So now that we've spoken a bit about your experience in neonatal care, we were wondering if we could talk a little bit more about the journey for you to get here where you are now and your journey to come. So as you reach the end of your pediatrics training, I heard that you're ST7 now. What are your aspirations for your career?
Yeah, it's slightly scary. I'm coming towards the end of my training. I'll be in ST8 in September, which is terrifying. It's terrifying. It suddenly feels very real, I suppose. And suddenly it's like, oh gosh, okay, fine, but that's just part of, I guess, only life transition, isn't it? Yeah, so what I would love to do, and one thing about neonatal spin that's different from neonatal grid, and anyone who was at the Gosh Summer School careers panel, we did talk a bit about this, is that neonatal spin gives you the flexibility to work in different levels of neonatal unit, but it's fundamentally aimed at working in a level 2 unit. So level 3 is the most acute, and level 1 is the least acute, and level 2 is somewhere in the middle. So it's mostly high dependency special care, and there's a little bit of ITU, but not as much as the higher levels. So that's essentially what I'm planning on doing, is becoming a neonatal consultant in a level 2 unit. And also there are different elements within job plans. So some hospitals, it would be there's elements of some general paediatrics, and some there's no general paediatrics, and some there's more than others. And that's all a bit different. And that's the bit that I guess at the moment I'm kind of flexible on, as long as I can have my focus on neonatology. So that's kind of what I want to do. And I guess at the moment I'm more thinking short term, in that I need a consultant job. So I guess that's my main short term goal. And yeah, I love doing neurodevelopmental care. I'm looking more at some of the nutrition elements as well for babies. So, kind of developing that interest as well moving forward. At the moment, I'm focusing on obviously completing my CCT and completing all my curriculum things and all that sort of stuff. So that's kind of where I am at the moment. I think long term, I would absolutely love, if possible, and who knows, to have a job where I worked clinically for some of the time and then worked in medical education for another part of the times. My experience has mostly been in undergraduate education, so I'd love to work for university, maybe a couple of days a week, particularly in paediatrics, I guess, because I'm a paediatrician, but there are different elements that you can do in terms of communication and that sort of stuff. But some of the transferable skills that we all have. That sort of thing I'd love to do. And it may be that happens. It may be that I end up going more down a postgraduate education sort of route and looking at roles like being a training program director or something in the longer term. So yeah, that's sort of where I am with things at the moment, and I guess we'll see what happens. You have to, hope that the right job is available at the right time. It's all these sorts of things. So yeah, that's what I'm aiming for really at the moment.
That's
Sounds
also exciting
amazing.
to think about. I think because medicine is such a long journey in a sense. I mean, like me and Letitia just before recording, we were talking about, it feels like it hasn't. I mean, I'm very much at the beginning of my journey here, but we were talking about how the 6 years that we'll spend at medical school are already kind of flying by so fast. I can't imagine what it must be like to be coming like near the end of of your training now. So, I mean, kind of leveling off of that, what have been like some of the most formative experiences for you during your training so far? Have there been any particular moments that have stayed with you throughout training and will continue to stay with you throughout your career?
Yeah, it's a really interesting one because I've been qualified for 12 years now. Most of it in pediatrics, but I did obviously do foundation beforehand. And I think there have definitely been some key moments within pediatrics. But I think reflecting back, like a big formative experience for me was actually one of my F2 jobs in palliative care. It was in a hospice for adults in Sussex, and it was an amazing experience. I think I learned so much there, not just about medicine. I did learn about medicine, obviously, like about life in general and what it means, what matters in life, and what matters to being human. Being part of a community, and often these it's in a relatively smallish town, I suppose. But yes, as part of a community there, and all those, and there are definitely some moments within that job that I sort of take forwards now and think about. And I think that's something that even now 10 years ago I look back and I think actually like that whole 4 months was a really formative experience for me. Even though I didn't become a palliative care physician, I still learned absolutely loads, and that experience for me was so important. I had the consultants there were amazing, and had some there that even just little things, like I had got on with one consultant who kind of understood who people were and kind of as core as people, and would be able to say okay, you go and spend time with that person who's in room 12 or whatever, because I think you two will get on well, or maybe that's not the right phrase, but probably isn't. Anyway, he'd be able to say I think this you'd be able to have a real impact on this patient. And there I was in my 20s, and this might be a person in their 60s, 70s, but he understood about humanity, the stuff that transcends age and the stuff that transcends circumstance, and was able to say, yeah, okay, you'll be able to make a difference in this family, and this family will have an impact on you. And he was always right. And I think a place like that, often you have people there like that, who really understands people and helps you to think about people as humans, not just people as medical examples or medical histories and stuff. And I think that was absolutely vital for me.
That's beautiful.
Yeah.
Thank
I
you.
think you really just highlighted that how medicine's just really about this human interaction, and we're all in it because of the patients, and we're here to help them, but we're also learning so much from them at the same time. It's really lovely. Um, our next question is a little bit back to what you were just saying previously about how you said you wanted to kind of integrate medical education into your long-term plan. And so at the time of recording now, so it's been a few weeks since the newest set of resident doctors have started their journey through this profession. So we know that you're quite passionate about the future of pediatricians. So with so many uncertainties about life in the NHS currently, what advice would you give to a resident doctor aspiring to specialize in pediatrics?
Yeah, lots of different things. I guess firstly, to all those people who've just qualified and who've just, were a few weeks in, like, congratulations on finishing. It's a hard journey to get there, but you've started, and that's amazing. I think for people who want to be pediatricians, I think a few things to say. I think first thing is, this is a tip I think for anyone for whatever career you want to do, is to really think about life as a consultant or as a GP. Because I think particularly as a medical student, right, you hang out a lot with the resident doctors because they were most recently at medical school. They may be a little bit less intimidating or whatever. You're closer in age, you've got things in common and stuff. And so, yes, absolutely, definitely spend time with them. You need to know if they're happy in their specialty and why they chose their specialty and stuff. But you're going to be a consultant or GP, whatever it is, for much longer than you're going to be a trainee for in whatever specialty you choose. So don't just make your career decision on what the trainees are like. Make your career decision on what consultant life is like, because that's going to be 30 years of your life versus 10 as a trainee, or, it's a bit different specialties, isn't it? But, you're going to be a consultant or GP for much longer than you will be a trainee. Like when I chose to do peds, one of the reasons I chose to do it was because so I did an F1 job in peds, and the consultants there, have been doing pediatrics for 20 years and still loved it. And I thought, gosh, that's what I want to do when I'm a consultant. And that's the sort of thing that I can see myself doing. So yeah, I would say definitely don't shy away from talking to consultants about what they like about their job, and about what their job is going to look like in 10, 15 years by the time you finish training or whatever. Yeah, I think whatever specialty it is that you happen to choose. And then from pediatrics, so firstly, I'd say try and get some experience. But if you can't get a foundation job, it is not the end of the world. It's probably how I describe it. So my F1 job was really helpful for me to make a decision in doing pediatrics. And that was in a London tertiary hospital, doing mostly general peds with a little bit of specialties. But I also, when I was in F2, was in a DGH, and I still arranged for myself to go and have a taste a week in DGH pediatrics, because I was like, well, I need to see what it's like in different settings. So you can go and get yourself the taster stuff in the super fancy tertiary hospitals, but also have a think about DGH peds, because that's where most people end up. So definitely do that. And it's relatively easy. When I arranged my taster week, I was doing an orthopedic job at the time, and the ortho ward happened to be next to the peds ward, and I just walked round onto the ward, found a consultant office, knocked on the door, smiled and said, "Hello, I'm Naomi and I want to do peds, can we arrange a taster week?" And it's it kind of went from there. So most pediatricians will be like, yeah, if you're keen and you introduce yourself and you say, this is what I want to do. Most pediatricians will be like, yeah, brilliant. Let's figure this out logistically. But yeah, I'll be up for it. And then I think I would say, so that's kind of it gives you the experience, helps you to then think about reflect, what you can reflect on at interview, and also in general just what you can reflect on to say, okay, actually, yeah, this is right for me, or to maybe say, oh, actually, I'm not sure about this anymore, and why that might be, because you want to make the decision that's right for you. So that's kind of think about how you make that decision. And if you don't happen to have a peds job, like I said, you can do a taste a week, but also try and use some other jobs for the transferable stuff. If you're an A&E, then go and work in peds of A&E, that sort of stuff. Most people will have an F2 job in A&E. Most people, if they don't have that, they'll have an F2 job in GP. Loads of kids in GP. So, use those experiences, every experience you can use. And then if you're thinking about yes, this is definitely what I want to do, how am I going to get into it? The main thing I would say is have a look at the RCPCH website, have a look at the ST1 person specification and what are going to get you the points. and focus what you're doing on what's going to get you the points. Don't waste time, basically, and try and be focused. So like something that Simon Broughton said at Summer School, which I thought was really useful, was like particularly think about teaching. To get your most points in the ST1 for teaching at the moment anyway, and like, this might change in the future, but he was saying like what it says on the person spec is that you do the teaching, that you get feedback, you reflect on the teaching, and you make changes to your teaching the next time, and then you get more feedback. And that's how you get the most points. And that will get you can achieve that quite easily by doing a little bit of bedside teaching on the ward with medical students, collecting the feedback, reflecting on it, showing evidence that you've done that. That's quite easy to do. So focus on doing something like that rather than stressing about, oh my gosh, I've not done a regional lecture to 300 people. To be honest, that will get you less points than doing bedside teaching that you've reflected on and changed as a result of feedback. I would say definitely like have a look at the person spec and focus on achieving that and achieving those points and what you want to do. And something else that Simon Broughton also said was they're really keen about how you reflect on your experiences. So also what have you done, but not just what have you done, but what have you learned from it? There's a question at interview where they have been using it last few years where they ask you to bring an example of something that's particularly impacted you, a particular situation. And when I've been doing interview practice with people in the past, the thing that people often fall down on is they spend absolutely ages describing the situation and not very long on the reflection. And it's the reflection that gets you the points. So even now as students, you can be practicing like how are you going to how do you reflect on things? How do you reflect on things within a time limit? Interview stations have time limits to really get your point across and to get across what you've learned. So yeah, I think they're probably my main tips. I think in general,
Right.
to focus on.
Oh, perfect. Unfortunately, that's all the time we have for this episode. Thank you for such a touching episode. I think that's how I describe today's episode. We spanned a lot topic-wise, but this was definitely something that made me, I think, a bit more aware of how multifaceted medicine is, how important and how much of an impact we have even on our kind of day-to-day rounds. So thank you, huge thanks again to Dr. Naomi Jones for sharing her insight, experience and passion for supporting young people.
That's right, my pleasure. Thanks so much for having me.
Thank you so much for joining us. I feel like one of the things that really stuck with me was how you told us about how important it is to even communicate with the neonates, and you're telling us how they have their own way of communicating, and I'm really excited to find out how that is in my pediatrics rotation soon.
Yeah.
Yeah, great.
Absolutely.
Fab. I hope you enjoy it. Yeah, it'll be just I guess also like when you do your peds rotation and you're obviously interested in peds, so I'm sure you will, but something else I always used to say to students when I was teaching fellow is like just get stuck in. Go and see kids, go and take histories, examine, and obviously that stuff you have to get signed off for, but also go and do some of the other things. Like, if the child's having a blood test, you can help distract them, you can help blow bubbles, you can talk about bluey, like all that sort of stuff. Just get stuck in and you'll get the most from it.
Definitely.
Absolutely.
Thank you so much.
Yeah.
Amazing. Great tips.
So, to all our listeners, if you're a medical student interested in neonatal medicine or medical ethics or both, we hope this episode gave you some food for thought, and we'd love to hear your thoughts via Spotify or Instagram. If you like what you heard, make sure you're following our new Instagram at teddytalks.peds for updates on when episodes will be released. Please rate this episode on Spotify and share.
Thanks for listening to Teddy Talks. See you next time.